morning all. Today we'll talk on something about the basics of invasive mechanical ventilation. Basically, this is going to be a slide presentation rather than showing the ventilators now. So we'll more concentrating on the theory part, but only the basics, because I think basics are more necessary than going high-fi. Okay. Actually, started from the times of Hippocrates, like how we are going to do an invasive ventilation. Basically, like introduce a cannula into trachea along the jawbone so that air can be drawn into the lungs. So the idea started then. So if you take up a ventilator support, it can be two types actually. Now we usually use the positive pressure ventilation, but it's, there was a time when there was a negative pressure ventilation also, like this during the polio times and all. Now what we use is basically positive pressure ventilation. And there are two types. One, as you all know, there's an invasive type and a non-invasive type. We discussed the non-invasive type last time, so we'll be going for the invasive type this time. So our plan is basically to go through the indication, basic modes, working principles, and something about weaning. Each topic, is a class on its own. It may be months of class on its own, but we try to cover some basic things. We're not going to touch upon a gas change principles, complications, unconventional modes, or ventilator strategies in specific diseases. But if you take the indications of mechanical ventilation, basically, initiation of mechanical ventilation is a clinical decision. It's the same as non-invasive. When the patient comes in, we'll be seeing the patient, assessing the breathing and other parameters, and then taking a clinical decision if we are going to intubate or not. Or here, if you're going for an invasive ventilation or a non-invasive ventilation. In any case, the patient needs the thing that the patient needs a ventilation based on clinical aspects, early ICU admission should be done. It's not be like, it's not waste time in ER or maybe in a ward or something. Then, once the patient comes into ICU, we have to see if we can avoid intubation or even non-invasive by evaluating the reversibility of the disease and overall medical condition. Maybe it's a pulmonary edema, maybe it's a bronchial asthma, something like that. Maybe with a nebulization or a plastics or something like that, maybe patient will improve and you don't need any type of ventilation. So basically, when the patient comes in, we have to assess if we can manage it with medical interventions rather than directly going into invasive or even a non-invasive ventilation. But you should be pretty ready to start an invasive, non-invasive ventilation as early as possible if it's needed. So basically, the patient has to be in an ICU. If you clinically think that the patient might need a ventilation. There can be two types of respiratory failure. One can be the pump failure, where the muscles and CNS component or the airway component is involved. Basically, the patient is drowsy because of head injury, many other things. So drowsiness can be one of the causes why you need a respiratory. The patient has a respiratory failure. Other can be the muscle fatigue, can be neuromuscular weakness or poisoning, or maybe a snake bite or something. Many causes for that. Then there can be an airway component like a bronchial asthma or a COPD or anything. That can also be there. Then can be to the lung failure also because of the failure of exchange of gases. That's also can COPD and all. Then blood flow, maybe pulmonary embolism, all those stuff. Then even if the heart fails or something, all these can be indications of that can cause a lung failure and can be an indication for ventilation. So if you take modes of ventilation, there can be many modes of ventilation. umpteen number and newer modes, all those things are coming up. But what we usually use is take out. If we take out all the other modes, what we usually use is assist control ventilation, the pressure support ventilation, then SIMV or synchronized with mandatory ventilation. That too has also been it's not favored now, and usually SIMV is now used in post-operative cases only, and I don't use that in my ICU. Many intensivists don't use that. Then CPAP, maybe in cases like obstructive sleep apnea, we might be using. So these are the usual modes. What we use is assist control ventilation, pressure support ventilation. So two main modes we are going to use, and CPAP also. SIMV only in case of a post-operative patient or something. So even though there are a lot of modes, these are the 4 modes that we're usually going to use. So when we see a graph or something, ventilator graphs, we have to differentiate if it's a spontaneous mode or a mechanical, or the patient is not breathing. So it can be done in a pressure time graph. You can see that there is in a spontaneous mode, there will be an inspiration which is going down from 0, and then there will be an expiration which will create a positive waveform, a negative waveform formed by a proximity. But in case of mechanical ventilation, where the patient is not breathing on its own, the machine is basically supporting the ventilation, the inspiratory waveform will also be a positive one, and expiration is also like that. So the basic difference will be this part where the inspiration will be producing a negative. So this will say that if the patient is spontaneously breathing or if the patient is mechanically being ventilated. So when you see a ventilator itself, you can say if the patient is spontaneously breathing or it's on a completely controlled mode. So if you take the first thing that we usually study, it's a controlled mandatory ventilation, CMV, simplest form of positive pressure ventilation. And what you do is, there are 2 types of controlled mandatory ventilation. One can be a volume control, what we call a VCV, and the other can be a pressure control mode. So one is delivers a predetermined tidal volume, that is the volume control mode. And when you deliver a predetermined pressure rather than the volume, you say that that is a pressure control mode or pressure control ventilation, pressure CMV, PCM. Then the inspiration is basically given by the machine, and the expiration is a passive thing. One thing that we are sure by this is an assured minute ventilation. So basically tidal volume into respiratory gives you the minute ventilation. So it gives an assured minute ventilation. So as I said, there can be 2 modes, volume control and pressure control. So in the volume control, what you can set is the tidal volume. Okay. The pressure control, what you set is the inspiratory pressure. So you'll be directly setting in the volume or tidal volume. Like we'll come to how you're going to select the tidal volume now. But what we are setting is basically the tidal volume. Other one is the difference that in the settings will be basically the control variable, or what you are going to set this in a volume control will be the tidal volume. The pressure control will be the inspiratory pressure. Because you are setting in the tidal volume, depending on the compliance of the lung and the change in compliance, bronchospasm developing or secretions or obstruction or something like that in the airways, and all those things, all those changes that happen in the lung can induce a change in pressure. So when you are setting a volume control mode and you are setting a tidal volume, what you have to monitor basically is the peak inspiratory pressure. So you have to keep a watch on the peak inspiratory pressure, so that in a volume control, you are going to look for the peak inspiratory alarms. So if the you have to keep it below 30, and that's what we are trying to, maybe 30, but it's basically the P plateau that we are going to monitor in case of a volume control. So what we'll be looking at is the peak inspiratory pressure. The monitored variable will be the peak inspiratory pressure. We'll see it later when we are setting the alarms. Then in a pressure control mode, we are actually setting the inspiratory pressure, how much of pressure you are going to get. Depending on the pressure change, there will be a change in tidal volume also. So, but in that case, when you're setting the pressures, what happens is, first, when there is a bronchospasm, you'll be setting a pressure, let us take 18 centimeters of water or something, and it delivers a tidal volume of around 380 or something like that. But once the bronchospasm is relieved by your medical admission, drugs and all, then the compliance of the lung will be better. So that 18 pressure that you have been keeping might produce a higher tidal volume. So 380 would have been the tidal volume that is achieved by the 18 at first when the patient had bronchospasm. Later, the patient becomes better. Lung condition compliance becomes better with your drugs and all. Then what happens is the tidal volume that gets delivered by the 18 pressure may go up to 600 or something, or maybe 500 or something. So what you have to monitor is basically the tidal volume that is being delivered. So when you set the alarms, you'll be setting the volume alarms. So in a volume control, you'll be set. What you will be setting will be the tidal volume. That will be the set one. But you'll be monitoring the pressures. In a pressure control, you'll be setting the pressures directly on the monitor, on the ventilator. But what you're going to monitor is the tidal volume. So in a volume control, you'll be setting the tidal volume, you'll be setting the respiratory rate, and the minute ventilation also will be there, depending on the tidal volume and respiratory rate. But keep watching the peak inspiratory pressure. In a pressure control, you'll be setting the inspiratory pressure, the respiratory rate, minute ventilation, but keep watching the tidal volume. So if you take the graphs, what you see is in a volume control, what you set is the tidal volume. So you'll be seeing the same tidal volume that is happening. In a pressure control, what you will be seeing is basically the pressure will be the set one, and the volume will change according to the compliance. So that is the difference. In a volume control, what you set is a volume, and the pressure control, you'll be setting the pressure. So what you're going to focus is basically, once you set the things, what you're going to focus is the peak inspiratory pressure in case of a volume control, the exhale tidal volume or the tidal volume in case of a pressure control. And then we will be seeing the acid-base balance by doing an ABG, and we'll be looking for the patient ventilator as synchronized once you set the first values. So basically the control mandate advantages are the machine performs entire upper breath, like post-cardiac arrest or something like that, or even case of an ARDS in the initial stages. What you're going to do is basically give sedation, muscle relaxants properly, keep the patient at rest, give rest to the lungs. Okay, because in case of a cardiac arrest or something, 30% of the output, cardiac output, is being used, is usually utilized for the respiratory part. So if you can take out the respiratory part, that amount of rest will be given for the heart. So usually what we do is we'll be keeping the patient paralyzed for maybe 24 hours or something, and then reassess and do the other things are okay, there is a seizure or something, and we might do all these things. In the ARDS also, in the initial phase, for to give rest to the lungs, we will be doing giving muscle relaxants, and that time the control mandate regulation will be very advantageous because it performs the entire work of breathing, and it gives a preset alveolar ventilation. We can because the rate the tidal volume is set, the rate is set, so it will give a preset alveolar ventilation. Disadvantages is basically patient ventilator asynchrony. If it's only the controlled mandatory ventilation, the patient tries to breathe in between, then the patient, the machine will start an assist control, it's only a controlled mandatory. So when the patient tries to breathe in, maybe the machine might not give the respiratory gas for the patient to breathe in, because it's only controlled mandatory. Then if the alveolar ventilation is very high, then can be respiratory alkalosis. And because the patient is on muscle relaxants and all for this, need muscle relaxants for this CMV part, there can be diffuse atrophy of the muscles, respiratory muscles. Then because we have to use sedation, paralysis, there can be problems due to that also. There can be to give a lot more sedation or for patients, especially opioids and all. There can be delirium happening. So all these are problems of the controlled mandatory ventilation. So because there were problems with the controlled mandatory ventilation, there came another mode like intermittent mandatory ventilation. It's almost the same as controlled mandatory ventilation, but patient is allowed to take spontaneous breaths, but the spontaneous breaths are not assisted. So this is something called the intermittent mandatory ventilation. So the spontaneous breaths will be depending upon the respiratory muscle activity that the patient can do. So basically, the graph will look like this. That the spontaneous ventilations are not being supported by the machine. That's what we call intermittent ventilation. Intermittently, they will give the US preset volume and all, or the pressure, but the patient is also allowed to breathe in between, and but it's not being supported by the ventilator. So the volumes in between will be very less, depending upon the muscular effort of the patient. So what it can cause is breath stacking, where the patient is trying to take a breath, but the machine will be giving a mandatory ventilation, and if they coincide, there can be breath stacking and all. So there can be asynchrony. So then came the mode of assist control mode. That is what is now available in all the ventilators. So CMV, all those intermittent mandatory ventilation, all those have been almost like gone. It's not being used now. Basically, what we see as CMV in ventilators is basically assist control modes. ACMV or A pressure control assisted. There is all these newer ventilators have only the assist control mode, where the patient allows the ventilator allows the patient to trigger. Okay, and all the triggered breaths are assisted, because assisted breaths, once the patient tries to take in a breath, if the patient is able to trigger the ventilator, the same as in non-invasive. If the patient is able to trigger, depending on the settings, then all those triggers are assisted by the ventilator with the same tidal volume as we have set. Okay, we have set 400 ml. It will give a mandatory breath and wait for some time depending on the rate we have set. And in between, if the patient is taking a spontaneous breath and it triggers depending upon your trigger settings, if it triggers, then that trigger breath is also supported by the ventilator with the same tidal volume. So there's no patient asynchrony. The patient asynchrony will be less, okay, with the ventilator. If the patient doesn't trigger, machine delivers a preset control. If you wait for some time, you give a breath, wait for some time, the patient takes in a breath to support. Otherwise, the machine will give a supported breath, okay, or mandatory breath. If the patient triggers, give a supported breath, which will give the same tidal volume as the mandatory breath. And if the patient doesn't trigger, then after a period, what setting, the inspirate time, depending upon the respiratory rate, if you are setting a respiratory rate of 15, then in 1 minute it will be giving a breath every 4 seconds. So the machine will first give a mandatory breath, wait for 4 seconds, see if the patient is triggering in between. If the patient is triggering in between, it will support with a mandatory breath. Otherwise, what the machine does is after 4 seconds, it will give another mandatory breath and goes on till the patient is able to trigger it. So what you're going to see in that graph will be like there will be a this is a spontaneous breath. That's a negative pressure that is being recorded at the start of inspiration. That is what we call a trigger. Okay, this shows that this particular inspiration or cycle is an assisted one. And if you see the second one, the blue one, there is no inspiratory, the downward deflection of the pressure form. And that shows that it's a mandatory breath or a controlled breath. This is what you are going to see in a assist control mode. This is what you're going to see. Basically, all the breaths patient is able to trigger, and the machine supports all the breaths with the same tidal volume that we have set. That is what you see in a assist control mode. So basically, what we do now is we will be starting the patient, intubating the patient with muscle relaxants, starting the ventilation. At first, depending on the muscle relaxants what we are given, depending on the duration of effect, the patient will be at first on the controlled mandatory ventilation. That was what we have seen first. And once the patient starts to take breaths, that will be supported by the ventilator, depending on the trigger we have set. Okay. That is what is happening. There will be no dysynchrony, or there will be less dysynchrony between the patient and the ventilator in case of an assist control. Then there is the other mode of synchronized intermittent mandatory ventilation. This is also another mode where there will be less of asynchrony between the patient and the machine, and it improves patient discomfort. But this is what you're going to see in a synchronized in the SIMV mode, where the spontaneous breaths are also allowed in between, and depending on the pressure support you're going to keep for the spontaneous mode, the machine will support the efforts, spontaneous breaths, and in between there will be mandatory breaths. The problem with synchronized intermittent ventilation, basically what the problem with SIMV is that it's basically used as a weaning mode, and what they have found is it's the worst weaning mode that can be used. So nowadays it's not preferred. It's not preferred as such, and usually used only in case of post-operative ventilation also, not in case of critical care. Now we don't use SIMV as frequently we used to do earlier. Most of us don't use it. Then the other one is the pressure support mode. It's almost the non-invasive type of what we discussed. Only thing here is the patient is on a tube. It's an invasive type of NIV, we can say. There are no mandatory breaths. That each breath is triggered by the patient, and each trigger is supported by gas flow to achieve a preset pressure. We are setting a pressure support for each triggered breath, and the patient decides the respiratory rate. It is basically a spontaneous mode. It's an excellent weaning mode. This is the mode which we are basically using for weaning any patient now. It is starting with ACMV, going to pressure support mode, and the only problem is if the patient stops breathing in between, the machine will be sensing, and there will be something called an apnea period, or usually it's 20 seconds, the apnea time. The machine will wait for 20 seconds to see, let's check the patient is breathing on its own. And for some cause, the patient is not breathing in between. The machine will wait for 20 seconds. The patient is not taking any breath within that 20-second period. The machine will go into an ACMB mode. That is what we call a backup breathing, apnea backup. Usual time that the machine is going to wait is 20 seconds. That is usually preset in that ventilator. When you are setting up a ventilator, we'll see that later. You should be setting up the apnea backup also in a pressure support mode. So this is what you're going to see in the pressure support. All the respiratory efforts are being triggered by the patient, and all the triggered breaths are being supported with the pressure, with the preset pressure. Okay. That is how you see in the pressure support ventilation. Most of the time, if you are not doing it properly, apnea backup breathing is often inadequate in case of only the pressure support or the pressure that is going to be given by the ventilator if the patient triggers a breath. And it can vary according to the patient's lung compliance and all. So the tidal volume is not assured. So basically, the combination of factors govern the ventilator function and interaction being like mechanical factors of trigger. We go by limit, we just cycling. Trigger is basically what is going to change the ventilatory or the trigger the ventilator for an inspiration. Limit is up to what limit the volume has to be delivered. That is a limit. That there are a lot of things we will just know the terms and go off. Cycling is basically changeover from what is going to determine like when the ventilator is going to change from inspiration to expiration. So that is what we call cycling. And physical factors like volume, pressure, time, and flow, all these things combine the ventilator functions and determine the interaction between patient and ventilator. A lot of things we have to go through all these things, but these are the main things. Mechanical factors like trigger, limit, and cycling, and physical factors like volume, pressure, time, and flow. These things interact and determine how the ventilator and the patient is going to function. I'll skip this. We'll go to the, now we will see what we are actually going to do, tinker with when we are setting a ventilator. As when a patient comes in, what you are going to do. It's basically spinning some dials. It all depends on what you are going to set on the ventilator. The ventilator is not going to do anything on its own. You have to set those things. So we'll just go through the basics of what you're going to do when you get a patient on ventilator. First, we'll select the mode. So once the patient, we have already discussed about the modes. Usually what we use are the ACMV modes. So it can be a pressure or a volume control mode. You can select any of the two. There are certain advantages for each. That's basically for a disease-specific ventilation or something like that. So let us take that we are selecting an ACMV mode. When the patient comes in, we think that the patient needs an invasive ventilation. We are going to intubate the patient, and we are intubated, and we have to set the we have selected the ACMV mode. So once we select the ACM mode, we are going to select what will be the tidal volume. So one dial that we are going to change is the tidal volume. Then other one will be the respiratory rate. How much of a tidal respiratory rate you have to fix. One thing what you have to keep in mind is like maybe the patient is very tachypneic. You're thinking around 40, 50, something like that when the patient came in. And you are never going to go step by step. We'll see what happens. Okay. So always keep in mind that the patient was breathing at around 30 or 40 maybe sometimes, or maybe more sometimes. And no ventilator setting is complete without setting the alarms. So we'll go by step, how we are going to do it. There are no systematic studies on initial ventilation, so it depends on patient to patient and primary disease process. Depending on the primary disease process and all, ventilator settings will be different. So you cannot just say that you're going to set like this and all for each and every patient. There are no systematic studies. Okay. So what you are going to achieve is basically trying to achieve an acceptable arterial carbon dioxide tension and maintain an acceptable arterial oxygen tension. So these are the two primary goals that we are going to do when you are setting a ventilator. So first we'll take up building the most of the pumps or any patient. First, what we are going to do is we'll be trying to maintain the oxygenation. So oxygenation is basically maintained. We try on a ventilator by tinkering with the FiO2 and the P. These are the two things we are going to tinker with oxygenation. So these are the two dials the parameters that you are going to adjust to oxygenation part. The second one that said is basically the maintaining a carbon dioxide, adequate level of carbon dioxide or appropriate level of carbon dioxide. So basically, the second is to ventilate the carbon dioxide out. Okay. To bring out the carbon dioxide is being produced inside, or the dioxide is being there in many patients. So first is oxygen, that is mainly by tinkering with the FiO2 and the P. Second one is the carbon dioxide. And carbon dioxide, we try to control it basically with tidal volume and the respiratory rate, basically the minute ventilation. So this carbon dioxide, so that is why we think we are concerned about the tidal volume and the respiratory rate. So carbon dioxide is controlled by these two, and oxygen is controlled by the FiO2 and the P. So we'll start by tuning with FiO2, the P, the respiratory rate, and the tidal volume. So these are the four parameters that we are going to first set on a ventilator. So how we are going to do this? So we will consider one by one. So we start with the tidal volume. So as we said, in a volume control or volume control mode or volume based mode, tidal volumes we can set directly. We can set tidal volume as 400, 300, 500, 600, something, whatever values. We'll go through the details later. In a pressure control mode, what you're setting is 18, 16, 15, or whatever it is, depending upon the tidal volume we are trying to achieve. We change the pressures, and that will change the tidal volume that is being delivered. In volume control mode, we directly set the volumes. In pressure control mode, we set the tidal pressures and achieve the desired tidal volumes. So, but the question comes, how much amount of tidal volume? Okay. We all know it's like 6 to 8 ml or something, and weight of 250 ml, 250 kilograms ml. This guy can have a weight of 250 or more. So, will you set a tidal volume of 2000? We don't know. Okay, because 6 to 8 ml for 250 will be around 2000. And for this patient who's having a height of 170 and a weighs 40 kilograms, will you give only 320? Is that what you're trying to say 8 ml per 2 ml per kilogram? What will you use? The first, when we started off some years back, even in anesthesia, we used to say 8 to 10 ml. So we used to say 8 to 10 ml per kilogram body weight. Then there were questions raised about this. Then we said 6 to 8 ml. So what is it, high or low? What is our current concept? Yeah, basically now the concept is basically of 6 to 8 ml per kilogram of ideal body weight. So it's not the actual body weight, it's the ideal body weight. Yeah, we all know that because it's basically 6 to 8 ml of ideal body weight. So how will you calculate the ideal body weight? Ideal body weight is given by these two formulas. So you need to by heart it, and when the patient comes in, actually the nursing staff should be doing this. So calculating it and writing down first itself, because many of the things are based on drug calculations, ventilator management, nutrition, all those things are based on the ideal body weight. Only certain drugs we give according to the actual body weights, like vancomycin or something. So this is the importance of calculating the ideal body weight. 6 to 8 ml per kilogram body weight of tidal volume per kilogram of ideal body weight. So this is one example that I'm going to give, how we are going to calculate. So 8, and the measured weight is 88 and height of 162.4. Actually, the ideal body weight will come around 60 kilos only. So like if you are actually giving, calculating according to the actual body weight, 88 into 8 will come around 700 ml of tidal volume. But for a 60 kilogram ideal body weight, the 8 ml will come around only 480. So that is going to be different. So you are not going to keep according to the actual body weight. It will be basically based on the ideal body weight. That will be calculated by this formula. So you have to know how you are going to calculate the ideal body weight. So 6 to 8 ml. Even we can use 3 to 4 ml. That is acceptable now in an ARDS. Severe ARDS cases, we will be using 3 to 4 ml only. And what we'll basically trying to achieve is what the concept of permissive hypercapnia. We don't want to keep tidal volumes and for the patient. There are a lot of other things like polytrauma, barotrauma, biotrauma, all those stuff. When you're using higher tidal volume, the lung can get injured by the tidal volume. Even when you're using a normal lung, like in an anesthesia case, we're giving a elective case, we're giving keeping a tidal volume of 10 ml per kilogram body weight and all. Even 2 or 3 hours of anesthesia, after that, the lung can get injured because of your high tidal volume. So even in anesthesia, you should be using only 6 to 8 ml per kilogram body weight. So in case of an ARDS and all those patients, should try to avoid injury to the lungs, accepting the lesser evil of permissive hypercapnia. If the pH is more than 7.15 when you are starting off a ventilator, ventilating a patient who's having an ARDS, it is acceptable. Don't try to increase the tidal volume and increase the pressures and cause lung injury. We have to keep it around 6 to 8 ml, even 3 to 4 ml of per kilogram body weight and ideal body weight tidal volume is acceptable. So depending on the patient's condition, we can accept permissive hypercapnia. So why we accept permissive hypercapnia is basically with in ARDS what we call a baby lung. There can be overstretch if you're using the normal tidal volume of 6 to 8 ml. So there can be stretch injuries, shear strains, all those stuff, and there can be increased pressures inside the lungs. So that is why we try to keep the plateau pressure or even the peak pressures below, not peak pressures, but plateau pressure below 30 to prevent barotrauma. And in case the compliance goes up and you are not monitoring the patient properly, the volume can increase, as in case of a COPD from 300 or 400 in case of a pressure control. We have discussed it earlier, where in a pressure control we are going to monitor the volumes. So if the volumes go up without us noticing the thing, or the volumes are too high, there can be polytrauma also. And all these causes biotrauma, where the body reacts. There can be inflammatory markers and the lung can worsen due to your ventilation. So all these things have to be avoided by using a low tidal volume. So basically, the tidal volume that we're going to set is 6 to 8 ml per kilogram of ideal body weight. That is what you have to keep. ARDS and all can go down even to 3 to 4 ml of tidal volume, accepting the permissive hypercapnia. That is, if the pH is more than 7.15 and you are able to ventilate the patient properly with adequate oxygenation, then you should accept it. That is the basic thing of selecting the tidal volume. What is next? So basically, next one is once we have selected the tidal volume, then it will be what is the FiO2. So because arterial oxygenation will depend upon your FiO2 also. As you know, every drug has an adverse reaction, and oxygen is also a drug. So we'll start off with, usually when you're starting a ventilation, start off with a FiO2 of 0.8, or usually we keep it at 1, that's 100% oxygen. Oxygen we keep first. And our target is basically more than 90% of SaO2 or a PaO2 of more than 60. What we usually say is SpO2 target of 88 to 92%. And other thing is, like, many people are concerned about using oxygen in case of a COPD patient, because they think there can be, the drive for ventilation or inspiration will go off if you are giving more oxygen. Not the case. You should not withhold oxygen to a patient, to any patient, if you're not able to achieve 80 to 92%. You should keep whatever oxygen is required, that is basic oxygen therapy dictum. You should try to achieve a saturation of around 80 to 90%, even in case of a COPD. You should give that much of oxygen. That will keep a SpO2 of around 80 to 92%. Don't deny oxygen to any patient. Okay. And when you start off with 100% oxygen, what happens is you'll be giving 100% oxygen, and there is no nitrogen or anything that is usually present in the air. So if all the oxygen is getting removed by the arteries, pulmonary vessels basically, then there can be collapse of the alveoli. So we have to bring down the oxygen from 100% to at least 60%. That is the target within 6 hours. Okay, that is what we are trying to achieve when you are using a ventilation. In many cases, it might not be possible. If that is not possible in case of any ARDS and all, if you are not able to bring down to 60% within 6 hours, then you prone. That is another indication for proning. So what happens is, if you're giving 100% oxygen, there can be collapse of the alveoli. So when you're giving 60% or something, then can be air also mixed along with the oxygen. So there'll be nitrogen, and it will prevent the collapse of the alveoli. So in the giving air mixture to the patient, the oxygen is carried away, leaving nitrogen behind, so preventing absorption of glycolysis. So that's what we are saying. We start off with 100%, try to bring down the FiO2 to 60% or less as early as possible. Okay. Otherwise, if you're not able to do it within 60%, within 6 hours, in the case of an ARDS and all, then it's time for a prone or changing the other parameters also. So like PEEP and all, because SpO2 will depend on the oxygenation, basically depends upon FiO2 and the PEEP values. We have to think about the PEEP also. So if you take only FiO2, we'll start off with 100% and try to bring it down to at least 60% or less to achieve a SpO2 of around 80 to 92%. That is our target. Next is respiratory rate. Once we have set the tidal volume and the FiO2, next is the respiratory rate. So there can be different respiratory rates. So what are you going to set? In general, adult patients will be breathing at around 12 to 20. So that is the range of respiratory that you're going to keep. And in assist modes of ventilation, it's better to keep a marginally higher rate to improve the phase synchrony between the patient and the ventilator. So if the patient is breathing at around needs of 12 to maybe 14 or 15, keep it a little higher so that there will be better synchrony. Usually we keep it around 12 to 20. But in case of like ARDS or when the patient is tachypneic and all, ARDS net suggests that can keep up to 35. So in many patients, we can keep the respiratory rate up to 35. That is acceptable to give, because when we keep a low tidal volume, we have to definitely maintain the minute ventilation. So if we keep a low tidal volume, then the rate should be higher to give the adequate minute ventilation to the patient. So it can go up to 35 in case of severe ARDS and all this stuff, all those other conditions. We usually keep a rate of around 12 to 20 in many patients, especially in COPD and all. When there is a problem with hypercarbia, we have to keep a lower rate, maybe 14 to 16 or less, so that you get more expiratory time for the carbon dioxide to go out. But in ARDS and all, where the hypoxia is the main issue, we can accept the permissive hypercapnia, but we have to keep it a higher rate so that we can achieve the adequate minute ventilation. So it can go up to 35. Then comes, so once you have set the tidal volume, the FiO2, and the respiratory rate, then comes the PEEP value. PEEP is the, we have already discussed positive and expiratory pressure. Can keep a PEEP of around 0 to 15 millimeters of water. There can be problems with excessive PEEP also, over distension, embolic trauma, and sometimes hemodynamic instability also. If the patient is hypovolemic, cardiac costs are there. What is shown in the graph, that difference from 0 to up, that is the PEEP. PEEP acts like a pole of a tent. It keeps the alveoli open, preventing collapse of the alveoli and aiding in recruitment of atelectatic alveoli. It will push open the collapsed alveoli also when you keep a PEEP. And it also prevents the smaller airway from collapsing. So if there's a positive pressure, the chance of the alveoli and the smaller airways from collapsing will be less. Keep like the pole of a tent, it will keep the alveoli from collapsing. That's what a PEEP does. So this is what you're going to see. The lower one is the alveoli that you're going to see. If there is no PEEP, there will be collapse with the alveoli and the airways. So when you are applying a PEEP, this is a PEEP, so it will keep the alveoli open and the smaller airways will not collapse. That what you see here, there will be collapse of these things. When you are applying a PEEP, there will be no collapse. Some other pictures where you can see that what the effect of PEEP is. When you are not applying a PEEP, that the alveoli will collapse during expiration time. Alveoli are going to collapse. But when you are applying a PEEP, there will be less of collapse. You can see the difference between these two. And during expiration, this is the amount of collapse that's going to happen if you're not applying PEEP. But when you're applying PEEP, the collapse will be less. The smaller airway will be open, and the alveoli will not collapse as much. This is another picture where the effect of PEEP is shown. This is the one X-ray before the PEEP is applied. The CT is also showing that the dependent alveoli collapse. Once you have applied PEEP, you can see the change in X-ray and in the CT also. This is the effect of PEEP. There is a recruitment of these alveoli, and the amount of alveolar collapse will be very low when you are applying a PEEP. So apply between 5 and 50 centimeters of water, and usually what basically by increasing the PEEP by 2 and finding out if what is the adequate PEEP and setting it at that level. That's another thing what you have to do. Maybe it's more practical side. So I'll just say that basically go up by PEEP by 2 and find out what is the best lung compliance or best oxygenation that can be achieved, and the adequate the optimal PEEP that can be there. We will discuss this later. So next, so once you applied the adequate PEEP, then what you have to look at is the trigger. Okay. So the trigger in all modes of controlled ventilation. In ACMV mode, basically the trigger will tell the machine if the patient's ventilatory effort has to be assisted or not. If you, depending on the trigger that you are going to set, the machine will sense that the patient is breathing or not. Okay. So typically the trigger is set to activate the assisted breath. The patient effort reduces to. If you're setting a pressure trigger, there will be basal airway pressure that is happening during expiration. During expiration, there will be an airway pressure. If the pressure falls below, that is what usually we set, minus 2 centimeters below the basal airway pressure that is there in the expiratory time. If the patient is taking a breath, there will be a pressure drop. If it is 2 centimeters below the basal airway pressure, then the machine will trigger. That is usually what we set, minus 2 centimeters of water pressure. And the pressure trigger, that is that's what we are saying, that if the what we usually set is a minus 2 centimeters of water, and in case of flow trigger also, what is happening is there is something called a basal flow of 3 liters per minute. Like during inspiration and expiration, there will be a flow happening through the circuit from the ventilatory side, from the inspiratory side, through the patient and back. So during expiration also, there will be a flow of 3 liters happening. So once the patient takes in an effort, the 3 liters that is going from the inspiratory end will not, if the patient takes in a breath, there will be some amount of air that is being sucked in, and the return flow will be less than the 3 liters that is the basal flow that is usually set on a ventilator. So when there is a change in flow, that is sensed by the sensors in the expiratory part, and the machine will trigger. That is what is happening in a volume or a flow trigger. There will be basal flow of 3 liters happening from the inspiratory to the expiratory through the patient. And when the patient takes in an effort, that flow that is coming out will be less. So that will be sensed by the machine, and the machine will trigger the ventilator to give a support to the patient. That is how a flow trigger works. Pressure trigger is basically the machine will be sensing the pressures inside the circuit, and when there is a drop in pressure, it will trigger. Flow is there is a basal flow that is happening, and if the patient tries to take in a breath, the return flow will be less, and that will be sensed by the machine, and that will be supported. So earlier we used to say that the flow trigger is better, but nowadays both are the same. It's difficult to say which one is the better one. Both are equal. Maybe there is some theoretical advantage for a flow trigger, but usually it's the same nowadays because the better machines. Then the other term is, one is trigger, the other one is sensitivity. It's just like if you set a trigger less trigger, that means there is a lot of sensitivity, and so if you keep a low trigger, then the sensitivity will be very high. The machine will sense even a small drop in pressure or flow. So what happens is if there is a slight change in pressure or flow due to the even the secretions, the machine will sense that the patient is trying to breathe and will try to support, and there will be a lot of patient ventilator asynchronous. So you should keep the trigger or sensitivity, whatever you're going to set in the machine, to acceptable limits. Usually what we set is pressure trigger or flow trigger of around -2 centimeters and 2 liters flow. Because if you set a low sensitivity, that the machine is not able to sense even a good effort, then the patient will have to take in a very good effort to trigger the ventilator. So there's a concept like trigger and sensitivity. Trigger sensitivity is basically when you set a higher trigger, the sensitivity will be very low. And when you set a low trigger, the sensitivity will be very high. So in some machines, you directly set the trigger value. In some machines, you set the sensitivity. So depending upon that, you have to make sure which you are setting. Either the low trigger means there will be high sensitivity. High trigger means there will be low sensitivity. So you have to find out what you are setting. So what more is there? The other one is the IE ratio. Usually, IE ratio is inspirator-expirator ratio. Duration of inspiration comparison with expiration. Usually we set an inspiratory IE ratio of 1:2 or 1:3. Depending upon the inspiratory flow rate, inspiratory time, the IE ratio can change and all those things. So I try to explain. I don't know how much you understand, but so the first portion is the inspiration, and the second one is expiration. There will be cycling of that is change from inspiration to expiration. If you drop a line like this perpendicular to this, then this will give you the inspirated time, and this portion will give you the expired time. So depending on the flow rate, that means if the flow is very slow, then it will take some time for it to reach the desired pressure. Okay, so the inspired time will be very high, or inspired time will be high, and the expired time will be less. But if you take that the flow is fast, then the inspired time will be less, because it will achieve the tidal volume or the pressure that you are set at a very lower time. The flow is very high. Like if you're trying to expand a balloon, if you push in air slowly, if you blow out very slowly, it will take more time for the balloon to inflate. But if you're blowing out very fast, then it will take lesser time for the balloon to inflate. It's the same as that in the lung. So if the flow is very slow, then it will take more time for the inspiration to happen. If the flow is very fast, or if you have a very high flow, then the inspired time will be less. So the same as what you try to inflate a balloon. So depending on the flow rate, also the inspired time and the expired time will vary. So basically the initial ventilator settings will be the tidal volume of 8 ml, 6 to 8 ml of per kilogram body weight of ideal body weight. Then the respiratory rate of 12 to 20 per minute, and can go up to 35. FiO2 of usually 1% or 100% oxygen. In IE ratio, usually we keep it around 1:2, 1:3. PEEP of 0 to 15, and we have to find out the adequate PEEP that will give you the proper oxygenation, adequate oxygenation and compliance. Then once you set this, it's a basic ventilator settings. Then what you have to do is we have to look at the alarm settings. No ventilator settings is complete without setting the alarms. So there can be pressure alarms, there can be volume alarms, there can be apnea alarms, and machine failure alarms. So the types of alarms, we'll just go through this. So basically, pressure alarms we will be setting in case of volume control. As we have said earlier also, once you set the volume, what we are trying to monitor is the pressure that is being built up by the tile volume that you're going to keep. So pressure alarms are usually set in case of a volume control. And in case of pressure control ventilation, depending on the compliance, change in compliance of the lungs, there can be change in volumes, and you want to avoid barotrauma or polytrauma, basically polytrauma in case of a pressure control ventilation. So in those cases, we'll be setting the volume alarms. In case of a pressure control ventilation, we'll be setting the volume alarms. And in a pressure support ventilation, we'll be setting up the apnea alarms. And in any case, there will be machine failure alarms, a lot of things which I'm not going into the details. So basically, we're going to set all these things. Then alarms for respiratory rate, because there are, if you take the alarms, there will be respiratory rate alarms. We will be keeping it a high respiratory rate alarm will be there, low respiratory rate alarm will be there. So in a high respiratory alarm, we'll be setting 10 to 15 breaths per minute over the observed respiratory rate. If the patient is breathing at around pre-intubation, we have set a alarm or respiratory rate of, let us say, 18. We'll keep it around 10 to 15 breaths per minute above the 18. So we'll keep it around 28 or something. If the patient breathes above 28, alarms should ring. So that is what we're going to set at the high respiratory alarm. That will tell you that the patient is becoming tachypnic with your ventilation. So we have to change the ventilation or do something to make the patient better or decrease the asynchronous. Then other thing what you set is low exhale tidal volume alarm. We usually keep it around 100 ml or 10 to 15% lower than the expired mechanical tidal volume. So if you see the ventilators, we'll be showing an inspirated tidal volume and expirated tidal volume. Usually the difference between inspirated and expirated tidal volume should be less than 50. Otherwise, there will be alarms because that shows there's a leak happening. And the expirated tidal volume should be set around 100 ml or 10 to 15% lower than the expirated tidal volume. The acceptable limits around 500. So if it goes below 50 ml is the acceptable limit usually. The difference between the inspirated tidal volume and expirated tidal volume. So if it goes above 100, then there should be alarms happening. So that shows that there's a system leak, a circuit disconnection, or cuff leak. So the alarm should be set for the low exhale tidal volume alarm also. Then minute ventilation alarm should also be there. If something happens either to the tidal volume or the minute or the respiratory, there will be minute ventilation alarms also. It's set at 2 liters per minute or 10 to 15% above the baseline minute. We will be setting some baseline respiratory rate and the tidal volume that will give you the baseline minute ventilation. We'll set the alarm at 2 liters above that or 10 to 15% above the baseline. And it also shows that the patients become tachypnic when the minute ventilation goes up. Respiratory distress is there when the patient becomes tachypnic. There will be an increase in the minute ventilation. That alarm should also be there. Then, in case of a volume control mode, you will be setting the high inspiratory pressure alarm. That is usually set 10 to 15 centimeters above the peak inspiratory pressure. When you set a tidal volume in the ventilator, there will be a peak inspiratory pressure happening. That will be shown on the ventilator. You should keep the alarm of the peak inspiratory pressure 10 to 15 centimeters above the peak inspiratory pressure shown in the ventilator. So if the pressure goes up by 10 or 15 above the peak inspiratory pressure that is desirable, then the alarm should be happening. So that common causes are water in circuit, kinking, or the patient sometimes bites the tube, there will be secretions and where bronchospasm, pneumothorax. All these can cause coughing, can increase the airway. So airway resistance high can increase the inspiratory pressure, and there should be an alarm. Otherwise, we'll never know all these issues, and the patient can collapse on the ventilator. Then there can be low inspiratory alarm that is set 10-15 centimeters below the observed peak inspiratory pressure. That can be due to system leak, the famous leaks or the low minute ventilation alarm, the same as that. That can be, when there is a drop in the pressure inside the circuit, there should be an alarm. That can point towards system leak or a circuit disconnection or a cuff leak also. So these alarms should also be set. Then we will set an alarm for PEEP. The high alarm for PEEP is set 3 to 5 centimeters above the PEEP, and lower alarm should be 2 to 5 centimeters below the PEEP that you set. So that will also show, the high alarm will show that there is circuit or exhalation manifold obstruction, and there can be auto PEEP in case of a COPD and all. So that can also be there. Then low PEEP will tell you that there is a circuit disconnect. Then there can be alarms for FiO2. FiO2 is basically preset in that ventilators. Usually, if it goes below 5% over the analyzed FiO2 or the low, if it goes 5% below the analyzed one, there can be alarms. That is usually preset in a ventilator. Then, if you're using a heated humidification, there can be temperature alarms also. Like if it is the high should not be more than 37 and low should not be lower than 30. That is what we said. Then can be apnea alarm that we already had told you. Basically in a pressure support mode of ventilation. When the patient is spontaneously breathing, the patient is not triggering the ventilator for 15 to 20 seconds. Then the machine should go into an apnea mode, or the machine should start giving a controlled ventilation. So when you set the alarms, there will be apnea in a pressure support mode, pressure support ventilation. There will be apnea ventilator settings also. That also you have to set. Usually we set at 6 to 8 ml per kilogram body weight, rate of 10 to 12, and FiO2 100%. That will give the patient goes in for an apnea during a pressure support ventilation. The machine will sense it if the patient is not taking a breath within 15 to 20 seconds and go into the apnea ventilation mode. That's basically to avoid collapse of the patient. Even if you are not noticing, the machine will go into an apnea mode where the patient will be fully supporting the patient. So what are you going to monitor? Basically, the first thing what you have to monitor is clinical thing, discomfort, agitation once you started this, and paradoxical breathing or excessively muscle use. All these things we have to clinically monitor when the patient is on a ventilator. And other thing what you have to monitor is heart rate, BP, respiratory rate, SaO2 and ATG. Once you started a patient on a ventilator, these all things have to be monitored. They have to be. That is why the nursing staff should be trained and they should be at the bedside, and the doctor should also be monitoring the patient. Any change in all these things can point towards the inadequate ventilator settings. If you don't change the ventilator settings, these things will persist, and you might get even a cardiac arrest. Then definitely monitor the alarm and ventilator settings. Even the usual thing what happens is when there is an alarm, we'll switch off the alarm or maybe give a muscle relaxation and increase the sedation and keep the patient under. No, you should see what is happening and try to correct the causes. That is what alarms are for. You should change the ventilator settings depending on the alarms. So you should know what the alarms are showing and what they point towards. That is what I just shown through some slides. I know it's not adequate, but you have to go and see what is happening. Then once I just go through the weaning part also, process of discontinuation usually happens within 3 weeks in more than 80 to 90% of patients. Many causes are there for weaning failures, usually pump failure or the respiratory muscles not acting properly because of many things can be a common cause of failure of weaning. When you start weaning process, definitely the primary condition should have resolved first, and the neurostatus of the patient should be good enough. There should be hemodynamic stability, and ABG should be normal. Okay, so if in simple terms, if these are met, then maybe we can think of starting weaning. When to initiate weaning, basically clinical judgment, and there are a lot of indices to say if the patient is ready for weaning, but just look into those parameters only, then like rapid shallow breathing index and all this stuff. It might not be successful many of the times. So clinical judgment plus the combination of all these factors should be there to have a proper weaning. There's no best method, but definitely spontaneous breathing trial and pressure support ventilation are very good. So basically what we nowadays use is ACM. First we'll be starting off ventilation with an ACMV, then going to pressure support ventilation and giving a spontaneous breathing trial, or even NIV, non-invasive ventilation. We directly extubate the patient from pressure support ventilation without even giving a spontaneous breathing trial. If the settings are less in a pressure support ventilation, especially in case of COPD and all, we might be able to usually go for an extubation and put the patient on a non-invasive and take the patient out from a non-invasive. So these are the basic weaning modes we now use: pressure support ventilation or spontaneous breathing trial, and sometimes, many cases, non-invasive also. Okay, that is basically about non-invasive, invasive type of ventilation.
നേരത്തെ ഒരു ആർട്സ് ARDS NET സ്പീഡ് ലിമിറ്റ് 35 അല്ലേ, അതൊന്നുകൂടെ ഒന്ന് എക്സ്പ്ലെയിൻ ചെയ്യുമോ? അത് ആർട്സ് നെറ്റ് സ്പീഡ് ലിമിറ്റ് 35 എന്ന് പറഞ്ഞു.
Speed limit is basically respiratory rate. The higher respiratory rate, what you are going to keep is basically up to maximum of 35. Because a patient breathe in, let us take when the patient comes in, he is breathing at around 50, okay, or 60 even. The patient and carbon dioxide, oxygen, whatever it is being maintained. Ventilation, carbon dioxide ആയിരിക്കും കൂടുതൽ അഫക്ട് ചെയ്യാൻ പോകുന്നത്. അപ്പോൾ നമ്മൾ ആ സമയത്ത് നമ്മൾ നോക്കുമ്പോഴത്തേക്കും ഈ ഇത്രയും മാത്രം പേഷ്യൻ്റ് ടക്കിപ്നിക് ആയതുകൊണ്ട് അയാളുടെ ABG ആ സമയത്ത് എടുക്കുകയാണെങ്കിൽ pH may be around 7.25 or 26 something, with a PCO2 of around 24 or വല്ലതും ആയിരിക്കും. അപ്പോൾ നമ്മൾ പേഷ്യന്റിനെ സ്റ്റാർട്ട് ചെയ്യുമ്പോഴത്തേക്കും നമ്മുടെ ഇത് വെച്ചിട്ട് നേരത്തെ പറഞ്ഞത് വെച്ചിട്ടാണെങ്കിൽ അഡൽട്ടിന് tidal volume of around 6 to 8 ml, respiratory rate of 10 to 12 or 12 to 20 വല്ലതാണ് വെക്കുന്നത് വെച്ചോളൂ. നാളെ പേഷ്യന്റ് നേരത്തെ ഒരു 300 ml വെച്ച് ഒരു ബ്രത്തിന് വെച്ചിട്ട് 60 പ്രാവശ്യം എടുത്തോണ്ടിരിക്കുക, ഓൾമോസ്റ്റ് ലൈക്ക് 18 liters. നമ്മൾ വെക്കുമ്പം ആ പേഷ്യന്റ് ഒരു 60 കിലോ ഉണ്ടെങ്കിൽ ഒരു 400 അല്ലെങ്കിൽ 7 ml അല്ലെങ്കിൽ 420 വെച്ചിട്ട് ഒരു 20 റെസ്പിറേറ്ററി റേറ്റ് വെക്കുകയാണെങ്കിൽ ആ സമയത്ത് ആ പേഷ്യന്റ് മിനിറ്റ് വെന്റിലേഷൻ വിൽ ബി അറൌണ്ട് 8 liters. നേരത്തെ പേഷ്യന്റ് വലിച്ചുകൊണ്ടിരുന്നത് 18-ലാണ്, ഇപ്പം നമ്മൾ 8 ലിറ്ററേ വെച്ചിട്ടുള്ളൂ. അപ്പോൾ definitely the minute ventilation has gone down. What will happen is the carbon dioxide will go up like anything. അപ്പോൾ ഈ 60 റെസ്പിറേറ്ററി റേറ്റ് വലിച്ചുകൊണ്ടിരുന്ന പേഷ്യന്റിനെ നമ്മൾ മെക്കാനിക്കൽ വെന്റിലേഷനിലേക്ക് മാറ്റുമ്പോൾ വി ഷുഡ് കൺസിഡർ ദാറ്റ്. ARDS ഒക്കെ ആകുമ്പം അങ്ങനത്തെ പേഷ്യൻസ് ആകുമ്പോൾ they will be breathing around very high rates. The tidal volume will be less, but the high rates will be high. But നമുക്കിപ്പോൾ 60 വെച്ചിട്ട് വെന്റിലേറ്റ് ചെയ്യാൻ പറ്റത്തില്ല. അപ്പോൾ നമ്മൾ ചെയ്യുന്നതെന്ന് വെച്ചാൽ 6 to 8 ml per kilogram body weight എടുത്തിട്ട് പക്ഷെ we can keep the rate at a higher level. Let us start at 25 respiratory rate, 6 to 8 ml per kilogram body weight. ഞാനിപ്പം disease specific ventilation പോയില്ല. അപ്പം അത് 25 എല്ലാം വെച്ചിട്ട് we can go up to 35 provided all the other parameters are controlled. P plateau അതൊക്കെ നമുക്ക് കൺട്രോൾ വെക്കാൻ പറ്റുമെങ്കിൽ we can go increase the rate up to 35 വരെ പോകാം എന്നുള്ളതാണ് തിയററ്റിക്കൽ പോസിബിലിറ്റി. നമ്മൾ 25, 30 ഒക്കെ വെക്കാറുണ്ട്. up to 35 വരെ പോകാം എന്നാണ് പറയുന്നത് to match the minute ventilation requirement for the patient. അതാണ് നമ്മൾ ARDS നെറ്റിൽ 35 വരെ പോകാം എന്ന് പറയുന്നത്.
ഓക്കെ താങ്ക് യു. പിന്നെ ഈ CMV അല്ല VCV PCV അല്ലേ, അതില് ഒബ്സ്ട്രക്റ്റീവ് ലങ് ഡിസീസ് ആണെങ്കിൽ പ്രഷർ കൺട്രോൾ മോഡല്ലേ നമ്മള്?
അതിന്റെ കാര്യം വെച്ചാല് ഒബ്സ്ട്രക്റ്റീവ് എയർവേ ഡിസീസ് എന്ന് പറയുമ്പോഴത്തേക്കും നമ്മള് ഒരു സ്റ്റെറ്റിസ്റ്റിക് അകത്തേക്ക് അല്ലെങ്കിൽ എക്സ്പിറേഷൻ ടൈം ആണെങ്കിലും ഇൻസ്പിറേഷനിലൊക്കെ ആണെങ്കിലും അകത്തേക്കുള്ള റെസിസ്റ്റൻസ് കൂടുതലാണ്. നമ്മളിപ്പോ ഒരു ട്യൂബിനകത്തൂടെ നമുക്ക് എയർ അങ്ങോട്ട് ഒരു സൈഡിലേക്ക് തള്ളി വിടണമെങ്കിൽ നമ്മള് ഒരു സ്മൂത്ത് ആയിട്ട് കോൺസ്റ്റന്റ് ആയിട്ടൊരു ഫ്ലോ കൊടുക്കുകയാണെങ്കിൽ അതിനെതിരായിട്ടുള്ള റെസിസ്റ്റൻസ് വിൽ ഓൾസോ ബി ലെസ് അല്ലേ? അതേസമയം നമ്മളൊരു ട്യൂബിനകത്തൂടെ എയർ പെട്ടെന്ന് തള്ളിക്കയറ്റാൻ ഹൈ ഫ്ലോ റേറ്റ് കൊടുക്കാൻ നോക്കുകയാണെങ്കിൽ നമുക്ക് അതിനെതിരായിട്ടുള്ള റെസിസ്റ്റൻസ് ഓൾസോ ബി വെരി ഹൈ. ഓക്കെ, അപ്പോൾ യൂഷ്വലി ഇപ്പോഴത്തെ വെന്റിലേറ്റേഴ്സിൽ സ്ക്വയർ വേവ് പാറ്റേൺ എന്നുവെച്ചാൽ കോൺസ്റ്റന്റ് ആയിട്ടൊരു ഫ്ലോ ഉണ്ടാക്കുന്ന ഒരു ഫ്ലോ പാറ്റേണും ഉണ്ട്, അല്ലെങ്കിൽ ഡീസലേറ്റിംഗ് പാറ്റേൺ, ഒരു പെട്ടെന്നൊരു ഹൈ ഫ്ലോ. അപ്പൊ നമ്മളിപ്പോ സാധാരണ ബ്രീത്ത് ചെയ്യുമ്പോഴത്തേക്കും നമ്മൾ ആദ്യം മാക്സിമം വലിച്ചെടുത്തിട്ട് വോളിയം കൂടി വരുന്നതനുസരിച്ചിട്ട് ഫ്ലോ കുറഞ്ഞു വരും. അതാണ് നമ്മൾ സാധാരണ ഫിസിയോളജിക്കലി ബ്രീത്ത് ചെയ്യുന്നത് അങ്ങനെയാണ്. ചില ഡീസിലേറ്റിംഗ് പാറ്റേൺ എന്ന് പറയും. ആദ്യം ഫ്ലോ വളരെ ഹൈ ആയിരിക്കും, പിന്നെ നമ്മുടെ അകത്ത് എയർ കൂടി വരുന്നതനുസരിച്ച് ഫ്ലോ നമ്മുടെ അകത്തേക്ക് എടുക്കുന്നത് കുറഞ്ഞു വരും. അപ്പം ഈ രണ്ട് ടൈപ്പ് ഓഫ് ഫ്ലോ പാറ്റേൺസ് ആണ് ഞാൻ അതിനെപ്പറ്റി കൂടുതൽ ഡിസ്കസ് ചെയ്യാൻ പറ്റാത്തതാണ്. അപ്പം ഈ രണ്ട് പാറ്റേൺസ് ആണ് നമ്മൾ യൂസ് ചെയ്യുന്നത്. അപ്പൊ COPD പേഷ്യൻസ് അതുപോലത്തെ ആകുമ്പോഴത്തേക്കും, ഒബ്സ്ട്രക്റ്റീവ് ടൈപ്പ് പേഷ്യൻസ് ആകുമ്പോഴത്തേക്കും നമ്മൾ ആദ്യമേ തന്നെ ഒരു ഹൈ ഫ്ലോ കൊടുക്കുകയാണെങ്കിൽ അവർക്ക് അകത്തേക്ക് നമ്മൾ ഒരു ട്യൂബിനകത്ത് കയറ്റുന്നത് പോലെ തന്നെയാണ് ഒബ്സ്ട്രക്റ്റീവ് ബ്രോങ്കിളിനകത്ത് കയറ്റുന്നത്. ഹൈ ഫ്ലോ കൊടുക്കുകയാണെങ്കിൽ അതിനെതിരായിട്ട് റെസിസ്റ്റൻസ് ഓൾസോ ബി ഹൈ. അപ്പോൾ നമുക്ക് അഡിക്വേറ്റ് ആയിട്ടുള്ള ടൈഡൽ വോളിയം ചിലപ്പോൾ അച്ചീവ് ചെയ്യാൻ പറ്റത്തില്ല. പ്രഷേഴ്സ് വിൽ ഡെഫിനറ്റ്ലി ഗോ അപ്പ്. പിന്നെ എവിടെയാണോ ബ്രോങ്കോസ്പാസം കുറവുള്ള അവിടത്തേക്ക് കൂടുതൽ എയർ പോകും. പല ആൽവിയോളയും കൊളാപ്സ് ചെയ്ത് പോകും. അതേസമയം നമ്മൾ സ്ലോ ആയിട്ട് കോൺസ്റ്റന്റ് ആയിട്ടൊരു ഫ്ലോയിൽ എയർ അകത്തേക്ക് പതുക്കെ കയറ്റുകയാണെങ്കിൽ ഇൻസ്പിറേറ്റ് ടൈം വിൽ ബി ഹയർ, പക്ഷെ എല്ലായിടത്തും ഈക്വൽ ആയിട്ടുള്ള എയർ എത്തും. ആൽവിയോളൈ വിൽ ബി മച്ച് മോർ, എല്ലായിടത്തും ഒരേപോലത്തെ എയർ എത്താനുള്ള ചാൻസസ് കൂടുതലാണ് സ്ലോ ആയിട്ട് കോൺസ്റ്റന്റ് ആയിട്ട് ഫ്ലോ കൊടുക്കുകയാണെങ്കിൽ. അപ്പൊ അതുകൊണ്ട് നമ്മള് ഈ ഒബ്സ്ട്രക്റ്റീവ് ഇതിൽ വരുമ്പോഴത്തേക്കും ബേസിക് തിങ് ഇസ് കോൺസ്റ്റന്റ് ഫ്ലോ കൊടുക്കുന്നതായിരിക്കും നല്ലത്. കോൺസ്റ്റന്റ് ഫ്ലോ ഇസ് ഹാപ്പനിങ് ഇൻ എ വോളിയം കൺട്രോൾ. പ്രഷർ കൺട്രോളിൽ യൂഷ്വലി ഡീസലേറ്റിംഗ് പാറ്റേൺ. അപ്പൊ അതുകൊണ്ട് പിന്നെ COPD പേഷ്യൻസിനൊക്കെ ബെറ്റർ ഓപ്ഷൻ ഡെഫിനറ്റ്ലി നമ്മളിപ്പം വെന്റിലേറ്ററിൽ നോക്കിയാൽ ഫ്ലോ പാറ്റേൺ കാണാൻ പറ്റുന്ന വെന്റിലേറ്റർ നോക്കിയാൽ അറിയാം. സ്ക്വയർ വേവ് പാറ്റേൺ ഉണ്ട്, ഡീസലേറ്റിംഗ് പാറ്റേൺ. നമ്മൾ COPD അതുപോലത്തെ പേഷ്യൻസിന് ബെറ്റർ ഓപ്ഷൻ ഡെഫിനറ്റ്ലി കോൺസ്റ്റന്റ് ഫ്ലോ ഉള്ള വോളിയം കൺട്രോൾ മോഡായിരിക്കും ബെറ്റർ ഓപ്ഷൻ. അതിലായിരിക്കും ബെറ്റർ ആയിട്ട് പേഷ്യന്റിന് വെന്റിലേഷൻ പ്രോപ്പർ ആയിട്ട് വരാൻ പറ്റും. എനിക്ക് മനസ്സിലായി.
ഓക്കെ, മനസ്സിലായി. പിന്നെ ഒരു ടാർഗറ്റ് FiO2 ഒരു ഡിസീസിൽ എങ്ങനെയാണ്, എത്രയാണ് ടാർഗറ്റ്?
എനി ഓക്സിജൻ തെറാപ്പി, അത് എന്ത് കണ്ടീഷനും ആയിക്കോട്ടെ, നമ്മുടെ ടാർഗറ്റ് FiO2 ഓഫ് 88 to 92%. അതിൽ അത് അച്ചീവ് ചെയ്യാനുള്ള FiO2 എത്രയാണെന്ന് അതിൽ വയ്ക്കുക എന്നുള്ളതാണ്. നമ്മൾ യൂഷ്വലി let us take that we get it by 40% FiO2 കിട്ടുകയാണെങ്കിൽ അത് മതി. We don't have to increase. 88 to 92% ആണ് നമ്മുടെ ടാർഗറ്റ് SpO2. അത് കിട്ടാനുള്ള FiO2 വയ്ക്കുക എന്നുള്ളതാണ് ചെയ്യേണ്ടത്. നമ്മൾ ആദ്യം സ്റ്റാർട്ട് ചെയ്യുമ്പോൾ വെന്റിലേഷൻ സ്റ്റാർട്ട് ചെയ്യുമ്പോൾ എപ്പോഴും 100% സ്റ്റാർട്ട് ചെയ്യും.
ടാർഗറ്റ് FiO2 എത്ര വേണമെന്നുണ്ടോ? പിന്നെ അതിൽ FiO2 നമ്മൾ കുറച്ചില്ലെങ്കിൽ ഇപ്പൊ 60 ആണ് ഇരിക്കുന്നത്, അഡിക്വേറ്റ് SpO2 ഉണ്ട്, അത് കുറച്ചില്ലെങ്കിൽ എന്താണ്?
നമ്മളിപ്പോ ഏതാണെങ്കിലും ടോക്സിസിറ്റി ഉണ്ടാക്കാം, ഓക്സിജൻ ആയാലും ടോക്സിസിറ്റി ഉണ്ടാക്കാം. അപ്പോഴത്തേക്ക് നമുക്ക് മാക്സിമം മിനിമം റിക്വയർമെന്റ് ഓഫ് ഓക്സിജൻ കൊടുത്താൽ മതി ഏത് പേഷ്യന്റ് ആണെങ്കിലും. അപ്പോൾ ഡെഫിനറ്റ്ലി ഏത് ഡ്രഗ് ആണെങ്കിലും അധികമായാൽ അമൃതം വിഷമാണ്. അപ്പം ഡെഫിനറ്റ്ലി ഏറ്റവും കുറച്ച് FiO2 നമുക്ക് 88 to 92% ഓക്സിജൻ SpO2 കിട്ടാവുന്ന ഓക്സിജൻ സെറ്റ് ചെയ്താൽ മതി. അതുകൊണ്ട് തന്നെയാണ് നമ്മൾ ഓക്സിജൻ ടോക്സിസിറ്റി കുറയ്ക്കാൻ വേണ്ടി തന്നെയാണ് നമ്മൾ കുറച്ചു കൊണ്ടുവരുന്നത്. പിന്നെ കൂടുതൽ ഓക്സിജൻ ഓക്സിജൻ വെക്കുകയാണെന്നുണ്ടെങ്കിൽ അറ്റ്ലറ്റാക്സിസും ബാക്കി കാര്യങ്ങൾ അബ്സോർപ്ഷൻ വരുമ്പോഴത്തേക്ക് അതിന് പ്രശ്നങ്ങളുണ്ട്. അഡൽട്ടിലായാലും ടോക്സിക് ഇഞ്ചുറീസ് ഉണ്ടാക്കാം, ഓക്സിജൻ ഫ്രീ റാഡിക്കൽസ് ഇഞ്ചുറീസ് ഉണ്ടാക്കാം. അതുകൊണ്ട് തന്നെയാണ് നമ്മൾ മാക്സിമം കുറച്ചുകൊണ്ടുവരാൻ നോക്കുന്നത്. അഡൽട്ട്സ് നമ്മൾ യൂഷ്വലി കീപ്പ് ഇറ്റ് അറൗണ്ട് മാക്സിമം കുറയ്ക്കാറുള്ള 40% വരെയാണ്. പക്ഷെ ഈവൻ ഇഫ് യു റെഡ്യൂസ് ബിലോ ദാറ്റ് ഇറ്റ്സ് നോട്ട് ആൻ ഇഷ്യൂ. അതില് if you discuss with certain other persons, they might even reduce to 30%. നമ്മൾ neonatology ഒക്കെ നോക്കുകയാണെങ്കിൽ they bring it down to less than that, because 40% ഒക്കെ they will say that it is toxic, because definitely it's toxic. Adults might be tolerating much more, so that is why we keep it around 40%. Some people, like some pulmonologists are concerned about even 40%, because COPD patient ഒക്കെ ആകുമ്പോഴത്തേക്ക് അതിനേക്കാളും കുറയ്ക്കണം എന്ന് പറയാറുണ്ട്. Usually we reduce it up to 40%. And ഇന്നത്തെ ഒരു കാര്യം വെച്ചാൽ ഈ 40% വാല്യൂ വെച്ച് നിർത്തുന്നതിന്റെ ബേസിക് റീസൺ we are able to wean out ചെയ്യുമ്പോഴത്തേക്കും നമ്മുടെ വെന്റിലേറ്ററിൽ എത്രയാണോ FiO2 അതിനേക്കാളും ഒരു 10% എക്സ്ട്രാ വെച്ചിട്ട്, ഇപ്പോൾ 40% ആണെങ്കിൽ 50% FiO2 കൊടുക്കാൻ പറ്റുന്ന രീതിയിൽ വെച്ചിട്ട് എടുക്കുന്നതാണ് നല്ലത്. അപ്പൊ അത് അത്രയും ലെവൽ വരെ നമുക്ക് കുറച്ചുകൊണ്ട് വരാൻ നോക്കുന്നു എന്നുള്ളത് മാത്രമേ ഉള്ളൂ. 40% FiO2 the patient is maintaining a 99 or 100% നിൽക്കുകയാണെന്നുണ്ടെങ്കിൽ you can even reduce it 35% 30% വെച്ചാലും കുഴപ്പമൊന്നുമില്ല. അതിനകത്ത് നമ്മുടെ ടാർഗറ്റ് ബേസിക്കലി ഇപ്പൊ നമ്മള് മാസ്ക് വെക്കുകയാണെങ്കിൽ we keep it around 25% or even. അത് വെച്ചിട്ട് നമ്മളെ പേഷ്യന്റ് SpO2 92% 93% ഒക്കെ ഉണ്ടെങ്കിൽ we'll accept that, അല്ലേ? അതുപോലെ തന്നെയാണ് വെന്റിലേറ്റർ, അതിനകത്ത് വലിയൊരു വ്യത്യാസമൊന്നുമില്ല. എത്ര FiO2 നമുക്ക് 90-92% അല്ലെങ്കിൽ 88-92% SpO2 കിട്ടുന്നത് അത് മതിയാവും. അതില് ARDS പോലത്തെ പേഷ്യന്റ് ആകുമ്പോഴത്തേക്കും വാട്ട് വി ടാർഗറ്റിംഗ് ഇസ്, ബിക്കോസ് നമ്മൾ 60% dictum is if you are not able to reduce the FiO2 to less than 60% within 6 hours, we have to prone, because early proning ആണ് ARDS മോർട്ടാലിറ്റി ബെനിഫിറ്റ് അല്ലെങ്കിൽ whatever it is അത് കാണിച്ചിട്ടുള്ളത്. ഓക്കെ, അതുകൊണ്ടാണ് നമ്മൾ ഈ ടാർഗറ്റ് വെച്ചേക്കുന്നത് 60% വിത്തിൻ 6 hours. പറ്റുന്നില്ല എന്നുണ്ടെങ്കിൽ പ്രോൺ ചെയ്യാനായിട്ട്. അല്ല, നമ്മൾ ലേറ്റ് ആയിട്ട് പ്രോൺ ചെയ്ത് കഴിഞ്ഞാൽ നമുക്ക് വിചാരിക്കുന്ന ഇത് കിട്ടണമെന്നില്ല, അല്ലെങ്കിൽ ഏർലി പ്രോണിങ്ങിനാണ് എവിഡൻസ് ഉള്ളത്. അപ്പൊ അതുകൊണ്ടാണ് നമ്മൾ ആ ടാർഗറ്റ് വെച്ചിരിക്കുന്നത്. 6 മണിക്കൂറിനകത്ത് നമ്മൾ 60% താഴെ കൊണ്ടുവരണം. അല്ലെങ്കിൽ അതുപോലത്തെ പേഷ്യൻസ് ആണ് ARDS പോലത്തെ പേഷ്യൻ്റ് ആണ് പ്രോൺ ഏർലി പ്രോണിങ് ആണ്. അതുകൊണ്ടാണ് ആ ടാർഗറ്റ് അങ്ങനെ വെച്ചത്.